Thank you, Dr. Chow, for the introduction. So my name is Abdulla AlAlool. As Dr. Chow mentioned, I'm one of the PGY4 cardiology residents from the University of Toronto. I'll be talking about echo and acute MI. So these are the objectives of my talk. Starting off with some background about the role of echo in acute MI. The learning point is that an MI is not just a coronary event. There's a lot of structural changes that happen with acute MI. And with that, an echo can really provide a lot of information that can help us in all stages of an MI. It can tell us where the injury is, it can tell us how the ventricles are responding, and it can often tell us if there's a complication in an MI early on that we should be mindful for, we should be monitoring as we move on. And when talking early on with an echo, especially for patients that are just presenting in ED, echoes are particularly helpful in patients that are presenting with chest pain and suspected MI, especially if they have unclear ECG changes. And on the other hand, they're also helpful for patients presenting with no chest pain, but with ECG changes or enzymes that are indicative of ischemia. Because with an echo, you can often get that last piece that's helpful to identify whether or not there's ongoing ischemia, and that's usually with regional wall motion abnormalities. An echo can also help define whether or not the LV systolic function is normal or reduced, and it can also tell you a lot of information about the RV involvement as well. So talking about wall motion abnormalities, the nice thing about wall motion abnormalities is that they happen very early on. So you'll see here that they often precede any ECG changes or any angina. And the nice thing about wall motion abnormality is that they can give you a lot of information very early on, especially within seconds of coronary occlusion. Talking about wall motion abnormalities and how they can present, wall motion abnormalities can often present either as hypokinesis or akinesis, and you can see here how they can appear on echo. With hypokinesis, it's usually defined as reduced motion and thickening, and with akinesis, usually defined as absence of motion or thickening. And with ischemia, you can often have early on hypokinesis, and then you can move on and see akinesis. There's also another form called dyskinesis that's happened more commonly later on, especially with chronic infarctions or aneurysms, and less commonly with early acute MI. And you can see here the picture is clearly depicting the hypokinesis and akinesis. And you can appreciate that with hypokinesis, it's reduced motion, whereas with akinesis, almost complete absence of motion. So this is the 17 regional wall motion abnormalities model that's depicted in the American Society of Echocardiography, with the 17th segment being the true apex. Now, with any echo, we're able to actually see all 17 segments, especially when we combine the peripheral long axis, the 2-chamber view, and the 4-chamber view. And with combining all those segments all together, we're able to have an understanding of how the heart is doing. And we're also able to kind of map it out into coronary territories to tell us how different walls are doing. And with that information, especially early on, even in the emergency room, we're able to kind of have a guess of which artery could be involved. And this is definitely helpful when planning for interventions and planning for cath as well. With that being said, though, it's important to understand that there's a lot of overlap, especially with the lateral and inferior walls. And depending on dominance and depending on which artery provides the PDA, whether it's the RCA or the circumflex, they can definitely be some changes in between echoes. And so it's always important to combine all this information with clinical presentations and also with ECG correlations as well. And all those diagrams are from the American Society of Echocardiography. We have some examples here. So you'll see on the first picture on the left, you can really appreciate how the apex and the anterolateral walls are almost completely akinetic. On the other hand, you have the infraseptal and basal anterolateral wall seems to be quite normokinetic. And in the middle picture, you'll see, once again, the anteroseptal wall seems to be akinetic, whereas the infralateral wall is actually hyperkinetic. And the same thing can also be appreciated in the 3-chamber view on the right, where there's hyperkinetic basal infralateral wall. And this finding is actually quite common. When you have one territory that's involved, you'll often see that the uninvolved territory seems to be hyperdynamic in a way to make up for the wall motion abnormalities in the affected segments. Some more examples here. You see that with the parasternal short axis, it usually provides an excellent assessment of all the walls together. So if you're able to get a good parasternal short axis early on, it can definitely give you a lot of information in the acute context. You can see here how the anterior segments seem to be akinetic. And with contrast, everything becomes clearer. You'll see here there's clear apical akinesis with no obvious thrombi that can be seen on this echo here on the right. Some pitfalls that we should be mindful for. First of all, if you have a foreshortened apex, as you can see on the right, it can definitely limit the segments that you are able to interpret. And sometimes it can have abnormal septal motion, especially in the context of a left bundle branch block or in the context of RV pacing, which can mimic wall motion abnormalities, but it's important to understand that those are mimickers, and they can definitely, you should definitely be mindful of those abnormalities and make sure that they're not to confuse them with regular wall motion abnormalities. You should also kind of review the history, check whether or not they have any old MI that can cause old wall motion abnormalities. And in general, if you're not able to properly have good endocardial definition, a contrast echo will always be helpful in those cases. There's actually been a lot of evidence over the past few years about the use of POCUS in acute MI. This was a trial that came out of Brazil just back in November of 2025. They used a protocol called the FAST STEMI protocol, where they looked at almost 200 patients presenting to hospital with STEMIs, and they incorporated a POCUS assessment of them in ED that combined both lung POCUS and cardiac POCUS. And they were able to show that by doing this FAST STEMI protocol early on, they were able to have a significant change in management or diagnosis in up to 14% of patients. And you can also see that a normal assessment of lung and cardiac POCUS was able to significantly have a significant negative predictive value of 97% for in-hospital mortality. So they really highlighted that early on with POCUS, you're able to have, it's a really good adjunct to your bedside evaluation and your ECG and your enzymes that can definitely help risk stratifications for patients early on. With that being said, we can now move on to our next topic, which is non-mechanical complications of acute MI. Starting off with acute LV infarcts. This is quite common, happens up to 10% of cases, especially with anterior MIs. And it's actually the leading cause of in-hospital death after acute MI. And therefore, it's important to be mindful for it. It's important to know how to pick it up on echo. And the teaching point about acute LV infarcts and how to pick it up on echo is that while yes, it can sometimes happen acutely, a lot of those patients that present with acute LV infarcts and cardiogenic shock actually have pre-existing cardiomyopathy. You can see here on the example on the right, you can really appreciate how the LV is dilated. You can appreciate how the walls are thinned out. And you can appreciate how the EF is globally reduced. So a lot of times it's helpful to know whether or not there's a history of pre-existing cardiomyopathy, where in that case, the acute MI possibly acted like an acute event that kind of tipped them into acute LV dysfunction, cardiogenic shock. And it's also helpful to know how to calculate LVOT VTI. This can easily be done through PW shot across the LVOT, and through simple calculations, which include multiplying the actual LVOT with the LVOT area. You can easily calculate your stroke volume and then continue with calculating the cardiac output and cardiac index. And this is particularly helpful and can even be done in a POCUS setting to really have a quick assessment of cardiac output and hemodynamics in someone presenting with suspected LV infarcts and cardiogenic shock. Next up, we have RV infarcts. Those are also quite common. In contrast to acute MI, this is more common with inferior STEMIs, where the culprit in case of RV infarcts is usually the proximal RCA, but can rarely be the left circ, especially in left dominant circulations. In cases of RV infarcts, the best diagnosis would be through ECGs, right-sided ECG. And the reason this is important to pick up on early on is because those patients are usually hypotensive and they're very fluid responsive, as we know. And the way to pick it up on echo is you really want to get that focused RV view on echo, and you want to appreciate the fact that sometimes the RV could be dilated. You can have reduced systolic function and reduced free wall motion. You can see here in this example, the right atrium is quite dilated, and there's actually septal bowing into the left atrium. And this shows that this is probably pre-existing. There's probably some pre-existing RV dysfunction in this patient. And sometimes, similarly to LV infarcts, you can also have an acute event that kind of tips them into heart failure and shock. Some more examples here. Once again, you can see the right atrium appears dilated. The walls aren't moving much. You can appreciate how it's down. And if you're able to calculate the RVS prime and you're able to calculate TAPSE, that's often very helpful because it can also give you additional information to predict RV dysfunction. Next up, we have ischemic or functional MR. And this is quite interesting because we can easily contrast this to papillary muscle rupture, which we'll be talking about in a bit. But with ischemic or functional MR, first of all, it's important to understand this is more common with inferior MIs. We'll talk about why in a second. But the mechanism that is thought to be causing functional MR is that with LV dysfunction and remodeling, you actually have displacement of the papillary muscles towards the apex. And especially in the setting of an inferior MI, this affects the posterior medial papillary muscle more than the anterolateral. And in those cases, while yes, both papillary muscles supply both leaflets equally, the exact angulation will definitely lead to tethering of the actual leaflet. In this case, you can appreciate how the posterior leaflet seems to be tethered more than the anterior leaflet. And it leads to incomplete coaptation of both leaflets with tenting or doming of the mitral valves towards the LV. And when that happens, you have MR that can either be posterior in one direction, or alternatively, it can be more central if both leaflets are being tethered equally. Looking at some examples here. So in this first example, you can appreciate that the posterior leaflet seems to be significantly tethered in the context of a severely hypokinetic inferolateral wall. And you can appreciate how the MR seems to be going more posteriorly. Likewise, with the apical 5-chamber view here, you can see how the MR is going it's more eccentric here, and it's going more posteriorly as opposed to central. In this example, you can appreciate how both leaflets are doming, or they're basically being tethered bilaterally towards the apex. And with that, the LV is clearly globally reduced. And the fact that both leaflets are tethered causes the MR to be more central, as you can see on the right. Just some more pictures of the same. You can appreciate that nice jet of MR going more centrally, still a bit more posteriorly, but nevertheless definitely more central compared to the previous echoes showing the posterior leaflet. So moving on to our next complication, which is LV thrombus. This is another one of those very common complications that happen particularly after anterior STEMIs, and it's important to pick up on because it can cause significant morbidity post-MI with embolizations, and it's important to be able to pick it up on echo. The main risk factors, as we mentioned, are anterior STEMI or LV aneurysm. And the echoes actually do pretty good. They have a pretty high specificity in picking up an LV thrombus. But if you have a high index of suspicion, it's often better to combine your echo with contrast, because as you can see here with the numbers, it significantly increases and doubles your sensitivity, and therefore should be used in high-risk patients. And in patients with a big anterior STEMI, always consider getting a repeat echo at 72 hours and at 1 to 2 weeks, because those LV thrombi can have a delayed presentation, and they become more obvious with time as well. I have some pictures here. So this is you can appreciate the multiple mobile masses that you can appreciate here at the apex. And this is basically, it's underlying a significant area of apical hypokinesis, which is, as we mentioned, the main kind of risk factor for this. And you can appreciate how the LV is severely dilated, it's not moving much, significantly reduced. Those are all complications, and those are all, risk factors for LV thrombi. Some more pictures here with another case. Once again, the LV appears quite dilated. And you can appreciate on the right how definity contrasts really help identify that there is an abnormal mobile mass there that's quite separate from the walls. And it can help seal in the diagnosis when you're not too sure. Next up, we have LV aneurysm. This is quite similar to what we mentioned before with the LV thrombi, in the sense that it can happen with anterior STEMIs mainly. The important differentiating part that we'll talk about more in a second with LV aneurysm is that with an aneurysm, it's really composed of all three myocardial walls kind of going through into the apex. And therefore, it can happen when you do have an LV aneurysm, what you'll see is that you'll see a clear bulge near the apex. And the key point about it is that it'll be moving in both diastole and systole. The other thing is that you can appreciate how the neck is quite wide relative to the fundus, with a big neck to sac diameter. And this is, again, quite key with LV aneurysms. This is a pretty high yield point when talking about LV aneurysms, and just to be able to differentiate it from LV pseudoaneurysms. And the key teaching point is that with an LV aneurysm, the myocardium is continuous, it's intact, versus with pseudoaneurysm, you have an abrupt discontinuation, as you can see on the diagrams and the echoes on the right, following which you have basically blood going outside, causing almost like a pseudoaneurysm cavity. And the cavity with the pseudoaneurysm is actually composed of pericardium and thrombus and not myocardial tissue, which is really the main difference that you can appreciate here. Some more examples of an LV aneurysm. You can appreciate on all views that there's this almost like an apical anteroseptal aneurysm that you can appreciate that's bulging, not really moving in systole and diastole. And you can appreciate that the LV appears to be quite dilated as well. With a zoomed in view, you're able to better identify whether or not there could be LV thrombi there, just because of the high incidence of LV thrombi in the context of an LV aneurysm. And you're able to get a better view of the aneurysm in general. So moving on to our next point, which is probably the highest yield part of our presentation, which is mechanical complications of acute MI. We'll jump right into them and talk about the first complication, which is free wall rupture. So free wall rupture is one of those nightmare complications that you'll see just because of the high incidence of morbidity and mortality that are associated with them. The classic teaching is that with free wall rupture, you have three main presentations. One is the acute non-contained blowout pattern, where you literally have the pericardium, basically the myocardium being blown out, causing massive bleeding, cardiac tamponade, and arrest. This is one of those things that you're more likely to catch on autopsy as opposed to echo, because the patients get very sick very quickly. You're often not able to catch them in time to do an echo on them. Versus a subacute or non-contained, once again, the second type, which is a subacute or non-contained pattern. This is also quite catastrophic. Nevertheless, the fact that it's oozing means it's probably a bit slower, and therefore you're able to catch them on echo, but they're still very sick and need immediate management. And the third form, which we just talked about with a pseudoaneurysm, it is a form of rupture, but this is more subacute, and it happens more chronically, and it can sometimes even happen up to months post MI. So this is the first subtype that we're talking about with the non-contained rupture. You'll see here with echo, you can clearly see evidence of impending tamponade with a large effusion, and in those cases, usually they present just very, very acutely within hours to days post MI. Luckily, especially nowadays with PCI and with even compared to the pre-thrombolytic era, that seems to be quite rare. It happens in only 0.01% of cases. Nevertheless, when it happens, it's quite catastrophic. And even with surgical interventions, mortality rates remain quite high, up to exceeding 35%. And you can see here on autopsy, you can really appreciate that free wall rupture in the ventricle near the apex with the arrow there on the diagram. Now, this is the more subacute form, which is the contained free wall rupture or pseudoaneurysm. And this, in contrast to the first presentation, while yes, it still represents a free wall rupture, it presents subacutely or more chronically. A lot of those patients are often asymptomatic, and the pseudoaneurysm can be found incidentally even a few months later. Sometimes they can be symptomatic, and they can cause heart failure, they can cause chest pain, they can cause arrhythmias or even embolizations. And the key points, like we talked about a few minutes ago, is that you appreciate that there's a narrow neck there, and there's an abrupt myocardial interruption. This is how you're able to pick up a pseudoaneurysm as opposed to an LV aneurysm. It's important to understand that even though they're asymptomatic, they are associated with a high risk of rupture, and they should always be taken to the OR even if they have no symptoms. Some more examples of an LV pseudoaneurysm here. Once again, you'll see the abrupt interruption there near the apex, and you can really appreciate it more in the zoomed-in views. And you can see that the neck appears to be quite narrow. You'll see that the extent goes into the pericardium, and that it's important, like we mentioned, is that all this defect there in the pericardium is composed of the actual pericardium and blood products as opposed to myocardium. There's no extension of the myocardium into the pericardium there. If we apply color, you can easily see flow going almost back and forth into the pseudoaneurysm. And with contrast, you're able to see that clear connection with the outside space as well, kind of sealing in the diagnosis there. Some more pictures of contrast there. And you'll see here how it's filling up that cavity there on the outside. We're moving on to the next complication, which is ventricular septal rupture. This is another one of those really scary complications because when they happen, it's very hard to manage, a lot of morbidity, a lot of mortality, but thankfully it is quite more rare nowadays. It happens in only 0.2 to 0.3% of cases versus up to 2% of cases pre-thrombolysis. When untreated, it's almost 100% mortality, so they definitely need treatment. But even with surgery, mortality rates reach up to 30 to 60%. They happen mainly with a tear wall MI, causing more of a apical type VSR. Nevertheless, there is another form of VSR which is more basal that happens more with inferior MI. Thankfully, it's more rare, but when it happens, it is associated with higher mortality and morbidity rates. Those patients are usually very sick. They present with shortness of breath, they present with shock, and the degree of sickness depends on the degree of shunting, going from left to right, and depending on their overall LV dysfunction. You'll see here with the echo features, you can appreciate the defect clearly near the apex. You're able to also appreciate some wall motion abnormalities near the septum. And oftentimes, if there's a significant degree of shunting, you might appreciate RV dilatation as well. With the use of Doppler, including CW and PW, you can also appreciate the flow going to the right side. And you can see here, just with color, you can see just how much flow there's going there. This is an example of a VSR, though. All those echoes are from the St. Mike's library of cases that we have in the echo lab here. You can appreciate how there's a large kind of ventricular septal defect there, distally, with a significant degree of flow. And you can appreciate how the non-affected segments, the basal segments, appears to be hyperdynamic, just to make up for the significant septal motion abnormalities there. And here you can appreciate that with certain views, you should be able to take different views and almost do a sweep-like motion to see the largest diameter that you can appreciate for the VSR. And by measuring the VSR, you can appreciate, and you're able to better understand the degree of shunting that you have ongoing. There's some more views. Those are all the same case. You can see with the subcostal view, you're able to also appreciate the shunting there through the VSR. So in terms of management, those cases are they're quite sick. So they need definite acute afterload reduction if you're able to tolerate the blood pressure. Ideally, this could be with a balloon pump, or sometimes they even need ECMO until you're planning for management. The mainstay of management is surgical repair. Nevertheless, there is emerging evidence for percutaneous closure. We actually have a case that I'll talk about in the end of the presentation about a case that underwent percutaneous closure here at St. Michael's Hospital. But essentially, this is emerging evidence that is done through an AV loop where they go through the venous system and the arterial system, and they kind of pull in a VSD closure device to close off the ventricular septal rupture. In terms of timing-wise, surgery, the classic teaching was that if you're able to delay surgery for up to 7 days, because of the increased scarring, you're more likely to have lower mortality rates. Nevertheless, a lot of times you don't have that luxury just because those patients are very, very sick. Moving on to our next complication, which is pap muscle rupture. This is, again, another one of those really deadly complications. Thankfully, quite rare, once again, with the reperfusion era. But nevertheless, when they happen, even with surgery, they can reach up to 40% in hospital mortality. It's important to understand that we have two pap muscles, the posterior medial and the anterolateral. The posterior medial is the one that's more likely to be involved because of their single blood supply from either RCA or the left circ, depending on dominance. When you have pap muscle rupture, you have acute onset of pulmonary edema, acute dyspnea, depending on how much flow you have from the LV to the LA. You can often have a murmur, but it's important to understand that because the pressure is rapidly equalized, it can sometimes be absent. And on echo, you're able to appreciate a flail mitral leaflet with the attached mobile mass that's actually the pap muscle itself. As we mentioned, both muscles attach to both leaflets. So depending on which chordae specifically, because most cases are usually partial rupture as opposed to complete rupture, but depending on which chordae are involved, you can have a certain leaflet being flailing more than another. And with pap muscle ruptures, TEEs are actually very important because you're able to better understand the anatomy of the mitral valve through the TEE, and you're able to better understand which leaflets and which pap muscles are involved. And it's also important for surgical planning. With CW, you have this beautiful V-shaped pattern that you're able to see This is in contrast to the more circular or more basically more linear pattern with classic chronic MR. And the reason that it's different is because in those cases you have lack of compliance of the left atrium because of how acute it is. And once again, as I mentioned, the color might be underestimated just because the pressure is rapidly equalized. Some examples here with pap muscle rupture, you can appreciate on the left with the person on long axis how the infralateral wall seems to be hypokinetic. And on the middle picture, you can appreciate how the anterior leaflet seems to be prolapsing with a significant degree of MR that's appearing more posterior, given the fact that the anterior leaflet's more involved. Some more pictures from the same case here. Once again, you'll see how the anterior leaflet is prolapsing. You'll see here how the MR is going more posteriorly. And you can appreciate on the right how there seems to be a mass that's coming in and out of view into the LV. This is actually the pap muscle head kind of bouncing up and down with the actual rupture. This is a close-up view of that mass there that's moving up and down. And with the two-chamber view, you're able to appreciate that eccentric posterior MR there as well. This is another example of another case with a TE. As mentioned, the TE, you're able to have a better understanding of the anatomy. On the left here, you'll see that both leaflets seem to be prolapsing. Nevertheless, the anterior part is prolapsing more than the posterior, and you can appreciate that the mass is jumping up and down. When you apply color, you're able to see that because the anterior leaflet is affected more, the MR seems to be going more posterior. Again, same case here. And you can appreciate leaflets kind of being flailed. You can appreciate how the MR is more posterior. In terms of management, so those cases need significant afteral reduction similar to VSRs, ideally with a balloon pump or vasodilators. Again, sometimes they need ECMO. And ideally, the teaching is that they need surgery within 24 hours. Once again, similar to with VSRs, there's actually emerging evidence for transcatheter edge-to-edge repair in pap muscle injury, and there's actually been literature about this as well, kind of highlighting that in patients that are too sick for surgery, an option can be transcatheter edge-to-edge repair. And you can see that they were able to identify that those patients were able to have a significant reduction in NYHA class symptoms. So I'll end my talk by talking about two quick clinical cases. Both are from the same Mike's library of echoes, once again, that are quite interesting. So starting off with the first case, this is a 77-year-old man who had a previous history of CAD up to almost 10 years ago, hypertension, lipidemia, and COPD and OSA. They presented to hospital with 2 months of shortness of breath, along with orthopnea, PND, and chest pressure. And they were basically diagnosed with heart failure on the basis of an elevated BNP level and clear evidence of pulmonary edema. They were quite hypoxic. They needed BiPAP. Their ECGs and their troponins weren't too impressive. They didn't have any evidence of acute ischemia. But then they had a CT scan that was done in Emerge for hypoxia, which incidentally revealed a large LV basal infralateral pseudoaneurysm. This was the echo that they had. You can appreciate how on the left, the infralateral wall seems to be hypokinetic. And you can appreciate how there's an echolucency that seems to be coming in and out of view adjacent to the left atrium. That's better appreciated on the right. And you can clearly see there's a big area of almost like an echolucency adjacent to the lateral wall there. And you can appreciate that with that wall, there's some tethering of the mitral valve leaflets, more posterior leaflet compared to the anterior. And on the parasternal short axis, you can see how the infralateral and inferior walls seem to be hypokinetic. When you apply color on there, you'll see that on the right side, there's actually color flow into that echolucency from the LV. And you'll see that with color across the mitral valve, there seems to be some MR with the posterior mitral valve leaflet tethering as well. Just some more pictures there. Once again, by applying PW across that interruption, you're able to appreciate that there seems to be bidirectional flow going back and forth. On the subcostal views, once again, you're able to see the echolucency quite clear. It's quite big. It's almost as big as the left atrium there. And with contrast, you're able to really appreciate the flow kind of shooting into the echolucency space, as you can see here on the diagram. And that kind of sealed in the diagnosis that there's a connection there from the inferior basolateral wall kind of going into this suspected pseudoaneurysm. So after this was done, they actually took them for cath, given the acute changes, and they found a CTO of the RCA. They found disease in the OM and LAD as well. And at that point, they became quite hemodynamically unstable. They required a balloon pump, and they required vasopressors. And the thought process at the time was that this could have been a possible silent MI, maybe resulting in the CTO RCA, causing a subacute contained LV rupture, resulting in a pseudoaneurysm. And the thought process was that they're in heart failure now from the pseudoaneurysm, presumably from the reduced forward stroke volume, just because of how big it is, and because of the functional MR with the tethering. And so they were discussed during heart team rounds, and just because, as we mentioned, this patient was unstable, but even if they're stable, those pseudoaneurysms always need to be taken for surgery. So they were discussed at rounds, and eventually they were taken for surgery for an LV repair and to reposition the PAP muscle and for CABG as well. The learning points is just that whenever you have someone with subacute heart failure in the context of recent ischemia, always think of structural complications. And the other learning point is that pseudoaneurysms can definitely present subacutely. A lot of times they can happen weeks or months after an MI. So we always have a high index of suspicion in those cases and think about it, especially in the context of someone presenting with heart failure a few weeks after MI. The second case is another interesting case that we have. This is an 83-year-old man who had a history of coronary disease with CABG almost 20 years before. They had a lima to the LAD. And they also had ischemic cardiomyopathy with an improved EF, with the latest EF up to 55%. And they had a CRTD in situ. They were actually planned for a routine generator change for their CRTD battery. And during the procedure, they had planned for an RV lead revision just because of deteriorating parameters that was found on device interrogation before that. During the procedure itself, the subclavian access was quite difficult, presumably because of scarring with his previous CABG, and they failed multiple percutaneous attempts. Eventually, they required a cut down with a subclavicular incision and with dissection, and then they were able to pass a guide wire there. However, there was significant manipulation just because of all the scarring there. And eventually, even with all this, they actually could not advance the RV lead just because of so much resistance at the subclavian SVC junction. And during the procedure, the patient had some chest pain, and therefore the RV lead revision was completely aborted. After the procedure, given the manipulation and chest pain, they had a CT scan that was done. It did show a small hematoma. However, there wasn't any active extravasation, and therefore the patient was discharged home. 2 days later, they came back with significant chest pain, shortness of breath, and delirium. Their troponin levels in eMERGE were up to 200,000, and they had an echo which showed a significant reduction in EF. As I mentioned previously, it was 55%. Now it's 25% with significant anterior and apical akinesis. So they quickly went for cath, just given the drop in the troponin levels, and it actually showed 100% proximal lima occlusion with a thrombus there, for which they underwent thrombectomy, balloon angioplasty, and stenting to the lima. The thought process was that they weren't too sure how this could have happened and how this related to the generator change. They thought maybe it could have been related to either the small hematoma causing compression, but they also thought that's a bit too small. So they wondered if it was all the manipulation that happened that could have caused it, but to this day, they're not too sure. Nevertheless, even after they stented his lima, over the next 2 days, he continued to be in cardiogenic shock. He required a balloon pump, he required DOB and norepi. And at that point, they had a repeat echo, just given his ongoing hemodynamic instability, which demonstrated that there was a small mid-inferior septal ventricular septal defect that's new, that's up to 4 millimeters. At that point, they were transferred because of consideration of closure of this VSD and also for management of cardiogenic shock. And the repeat echo that we have, that I'm about to show 4 days later, showed that there was a significant VSD to 10 millimeter up from 4 millimeter before, with a significant QPQS ratio of 2.7 to 1 and a significant shunt flow as well. This was the echo that they had 4 days later. You can appreciate how the anterior septal wall seems to be hypokinetic there. And you can appreciate that even on the paracentral short axis, you can really see that ventricular septal rupture there. With the apical core chamber, you're able to appreciate that defect, and you're able to appreciate that flow going through the defect with the septal akinesis as well. And just some more pictures. This highlighted how, with a sweep, you're able to see the maximum degree of shunting. And you can see here how it just kept getting bigger and bigger, eventually showing how much flow there's actually going. It's actually is going from the left to the right. And I kind of get to appreciate the septal akinesis there. The subcostal view also allows you to kind of calculate Doppler studies with CW across the actual defect, showing the significant degree of flow. So the patient was continuing to be managed for cardiogenic shock with DOB and norepi and a balloon pump. They also had a Swan-Ganz catheter that was put in to optimize fluid status, kind of diuresis, carefully targeting a wedge pressure of almost 10 to 12. And the case was discussed during heart team rounds, and he was found to be not a candidate for surgery, just given the age of the dysfunction and shock. And therefore, he was planned for a percutaneous VSD closure, and actually underwent the VSD closure with intracardiac echo guidance. And after the procedure, they noted that his blood pressure had significantly improved and his shunt flow had reduced. This was done here at St. Michael's Hospital as well. And you can see, you can appreciate on the left side, this is the LV angiogram showing the degree of shunting pre-VSD closure. And you can see on the right, you're going to see that VSD there in place, causing a significant reduction in the degree of shunting. And the middle diagram kind of there, you're able to see the VSD closure device kind of in there in the ventricular septal defect. Once again, this is done through an AV loop where they go in through the venous system and the arterial system. A guide wire is pulled in basically from the right side after it gets across from the left side. And through that, the VSR is then pulled in into the actual defect and put there. It doesn't cause complete absence of the flow, but it definitely causes a significant reduction in the degree of shunting to hopefully improve the hemodynamics. Just the key learning points here in the end is that a VSD can be small and can become bigger, so always keep an eye on for that. And with the degree of shunting, you can definitely have shock depending on how much shunting there is. And similar to the pap muscle rupture case, transcatheter therapies can be life-saving, especially with patients that are not surgical candidates and should be considered when feasible. Those are my references. Thank you.